My name is Azzy. I'm one of the nurse practitioners in the cardiac ICU. It is my absolute pleasure to be chatting with you about this topic. It is a topic near and dear to my heart, although I will not claim to be an expert in any way, shape, or form about any or all of these topics. So the idea for today's presentation on my end is to really do a case-based discussion and to really get into how you would set your mind frame to try and tease out what's going on for each of these patients. So without further ado, I have no conflict of interest as it relates to this particular topic. And it's just a particular topic of interest for me, and I'm on the pain and sedation committee here to try and better how we manage our patients from this perspective overall. So I'd like to pose a question to the group and ask, just think or consider what are some of the challenges associated to diagnosing and managing pain, sedation, and delirium in our critically ill patients. Some of the things, as you may imagine, are that for the most part, the symptomatology between the three is actually quite similar. Most of them present with agitation, and physiologically they have elevated heart rate, blood pressure, they might be crying, they're sort of disorganized. So the symptomatology between the three, you can imagine, are pretty similar. Some of the drugs that we actually use, for example, to sedate our patients when they're agitated actually can exacerbate and worsen some of the other parameters. So for example, some of the drugs that we give for sedation, they actually worsen delirium and contribute to pretty bad delirium, as I'm sure you heard from Laura earlier. It's not really a consistent state. So it's not a physiological state where you enter and sort of stay within it. It can vary with respect to when it comes on and when it goes off. And you may not consistently be in it, either with the same symptoms every time or at the same time. That sort of changes, and it makes it harder to be able to tease out what's going on. There is an element for sure of hemodynamics associated to the patient themselves that can affect, their state of pain and agitation and delirium. So in addition to that, also other issues that relate to how you absorb drugs or metabolize them can also complicate it further. So think about, patients who have GI malabsorption, things like that. And also between different patients with even the same diagnosis and the same age, they actually can present differently or respond differently to how we treat one versus another. So there's quite a degree of variability between them as well. So I know that you've gone through the actual details of each one of those, I'm going to call them states, today being sort of your day relating to this topic in particular. So I will not be going through any one of them in detail, but what I will try and do is actually present a framework, which I think is more so meant to help you think about this, this topic in a very structured manner. Because if you share sort of the same framework across the board, the different people can actually assess the same setup the same way, and you can communicate then in a similar fashion. It also helps you be a bit systematic, and so if there are things that you may potentially miss, it's just easier to catch up on it this way. So the first thing usually that I look at is assessing for pain. In the setting of kids who are in a cardiac ICU in particular, many of them are post-ops, and so pain can be an easy thing to think about and try and wrap your mind around whether that's contributing to what's going on at that point in time. So think about it in sort of the way of where your patient is at, what their context is. Does it fit for them to be in pain? Are they fresh post-op, or are they in sort of chronically for heart failure or some other symptomatology or etiology that doesn't necessarily cause pain? If they've just had a procedure, how painful do you anticipate the procedure to be? And is their response in keeping to the magnitude of pain that you're seeing? So, if it's a PIV insertion, the pain associated to that is relatively minor compared to, chest closure when your sternum is actually wired together. So the magnitude of response is always a good thing to keep in mind. Can there be another organic cause to the pain? And this is actually really, really important because some of the examples that I've actually listed, neck, GERD, DVT, SBC syndrome, some of them are actually really, really important, and they can actually be very, very consequential for our patients if it's missed. So for them, it's really important to be really mindful and considerate when you're assessing for pain, particularly children who are in heart failure. They're at high risk of developing neck and often being fussy and being in pain, quote unquote, or that sort of general presentation can be one of the earlier signs of tipping you towards thinking of other organic causes to this sort of presentation. Really, really important to always score pain and always score the response you get after giving analgesia, because you want to know if what you did actually worked. And if it did, then great. You know that it was pain, you gave an analgesic and it worked. But if it didn't, then it should be a sign that either you didn't give it enough of a dose or it wasn't pain to begin with. But it should be a flag to go back and reassess. Next, it's always good to assess for agitation. Again, consider your patient context. Are they just emerging with lots of tubes and accessories attached to them? In that case, then, they have good reason to be agitated. Can there be, again, an organic cause to agitation? And here, heart failure comes in again, because oftentimes kids who are in low output state, they present as very agitated and restless. And that's simply in the setting of the fact that they generally can't create enough cardiac output to give them that sort of energy to be a bit more chipper. They tend to be agitated. But other things that can actually also present as agitation are things like fever and infection. So you can potentially be approaching a septic state, for example. And one of the early flags would be presenting with a degree of agitation and restlessness. Consider if there are environmental causes to agitation. So, like many people, if there's too much noise or too much light, if they're afraid or if they're anxious, all of these things would contribute to agitation. And so consider the patient's age and where they're at, again, in conjunction with their context to assess for agitation. Always, 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 if you find patients are agitated, assess for delirium, because this is very important. Our patient populations are quite prone to this. And remember that withdrawal is always a diagnosis of exclusion. The reason why we say it is that while it's easy to go to withdrawal as a potential cause for agitation, there are a couple of things that we should always keep in mind. First is all the items that we discussed above. So looking for an organic cause and looking for other triggers that could potentially lead to agitation and this symptomatology that can mimic withdrawal. And if we settle on withdrawal, it's sort of as a first line, it's very easy to miss some of these other more important causes of agitation. And the second part is to sort of keep in mind is that you can't really be in withdrawal if we haven't weaned anything. So that means that in addition to all the things that are continuously running, also keep in mind that there shouldn't really be a change to the PRN frequencies as well. So if none of those has changed and they're getting the same exact drugs, both as scheduled infusions and PRNs, then they really shouldn't be in withdrawal. And that should require, again, another reason to take a closer look and just be really, really thorough and careful. And then lastly, is considering whether this is delirium. Again, in this case, patient context is important. So, younger patients or older patients within a certain range are more prone to developing delirium. If they've developed acute illness, for example, they're more prone as well. Always important to take patient context into consideration. Consider the environment. This is something that we look over quite often. And the ICU environment is absolutely just set up to cause delirium. So be mindful of that. really consider temporal correlation between onset of symptoms and any changes in either patient's state or medications. So you can sometimes see that when we start a certain medication, that patients become more agitated and more delirious compared to some of the other ones. And if you can map it out, you can sometimes identify the agent that's causing it. And it would be easier to correct for or treat delirium by then identifying the appropriate agent. So always take that temporal consideration in mind. Always score it. Because then we can track how it changes as we change our management. And of course, when it's present, we should always treat it. And sometimes it's non-pharmacological strategies, and on occasion there's a need for medication, for a medical management of it. And either way, it needs to be a conversation and a plan in place to actively treat it. Of course, it's always better to prevent it when possible. So for patients that you know are at risk, it's always better to set them up for success and prevent against developing delirium by some of these non-pharmacological measures that I'm sure Laura spoke to you about. So with all of that said, let's go through some cases. So first case example is that of an 8-year-old boy who had an ASD closure, a surgical closure of their ASD. They were not on any home medications, and they had good weight gain at home and otherwise healthy. In the OR, they received gas induction with dexmedetomidine and sufentanil for the case, and afterwards were extubated and sort of came to us. With chest tubes and pacing wires, as well as an art line and a CBL. So a standard sort of post-op assortment of accessories when they come to us. The procedure itself was straightforward. The ASD was closed. It was a simple pump run, no concerns, no residual lesions. However, as you can tell by this graphic, you know, in about 20 minutes or so, you've been looking after this patient post-op, and, you know, based on our routine, you've done an x-ray, and following that x-ray, your patient is crying and moving all over the bed, and they're tachycardic and hypertensive and just really miserable, and parents are at the bedside, and now they're miserable and really worried. So what do you do? Oh, and by the way, your alarms are going off. Just perfect. What do you do? So the question I'm going to ask, I don't know if anyone's online, but the question I ask myself and I ask of you is, what's going on? And I want you to apply sort of the same framework that we talked about earlier. So is this pain? Why or why not?
There's 28 online. So anyone can put your mic on.
I think it's definitely possible that it's pain because this patient is fresh post-op and has lots of chest tubes, pacing wires, lines, and stuff.
Excellent. Can it be agitation? I promise I'm not as scary as I sound. Tell me.
Yeah, I think it could be agitation because we just had to move the patient for an x-ray. The parents are at the bedside upset, the alarms are going off, we probably have all the lights on, maybe they're still uncovered because we're assessing them.
Totally. You're an 8-year-old in a foreign environment with everybody around you that you don't know, lights on, and a whole bunch of stuff that, yes, people told you were going to have, but you're 8, so you don't remember. 100% you could be agitated. Yes. Can it be delirium?
Oh, they're saying yes.
Oh, should I pull my chat box? Hang on, let me find it. Yes, it can be delirium, but it's very unlikely, and I'll tell you why. Usually, kids of this age group, when they're fresh post-op, usually they don't develop delirium this quickly. And so you're probably better off trying to figure out whether it's pain in the first place, because like it was said earlier, this kid has come back from the OR, they had their chest sort of opened up and they just had an x-ray, so they've been moving around, they have chest tubes and everything, they could definitely be in pain. And it could certainly be agitation to a certain extent because of all these other factors that we talked about earlier. So we talked about scoring for each of these things. And if I show you all these pain scores that we have, you know, these are sort of the 3 pain scores that we use. This is the FACES. This is sort of the numeric scale, which Sick Kids has made it into a thermometer, I think in keeping with COVID times. And then there is the actual FACES that you can score from. So from these 3, the FLAC, the numeric, and the FACES, you know, most appropriate for this patient is probably the FLAC score, because I don't think they're going to be awake enough or conscious enough to tell you verbally how much in pain they are. And you can probably make an assessment based on this pretty accurately. And you can potentially choose to give them like a 6 or so. And then assessing for agitation, the scale that we use for agitation is of course the RASS score. And if you kind of go based on this and the brief scenario that I told you, you could probably give them somewhere between a 2 and a 3 as this agitation score. So we're going to pull up this, make a score of that. And, you know, we decided that it's probably not delirium, but you're going to use your CAPD and make an assessment based on that. So, oops. So pain seems like a reasonable target to go after, especially if you score it as pretty high. And so what do? The most important thing in these sort of scenarios that you encounter on a regular basis is you always want to try and break the cycle. So if they're very agitated and they're sort of completely disorganized, it's really helpful if you can break the cycle. And so in this case, I would actually give a morphine bolus first to offset the pain. It's the easiest thing to sort of rule out from your differential and then see where you go. Once you've done that, because we think there is an element of agitation probably going into this as well, have mom and dad come by the bedside and have them offset some of the agitation by being those safe anchor points that they can then refer to. And of course, comfort measures and other safety items as appropriate for the age group. For this particular group of patients who are fresh post-op, one of the things that's a little bit underappreciated is minimal handling. As they emerge from anesthesia, sometimes their degree of agitation is out of keeping with what's actually going on with them. And that can be exacerbated further by a lot of handling and, you know, doing a lot of things to them. Whereas if you slowly allow them to emerge and have these drugs wear out of their system, they tend to emerge and come around in a more calm and collected manner. Keep in mind that this is scary for parents as much as it is for kids. So oftentimes they both need a fair bit of reassurance and distraction. Actually, before I get into this, I started off here by telling you that this patient was induced with gas anesthetic and had dexmedetomidine and sufentanil for the case. Anyone know why I told you this piece of information? You can take a wild guess.
Reactions to the anesthetic?
That's a part of it, yes. What else? Oops. Is anyone familiar with sufentanil, for example, or dexmedetomidine? So sufentanil is a narcotic. It's from the family of fentanyl, and it's way more potent, but it has a very short half-time. And so if this is what the combination they were getting in the OR, keeping in mind that dexmedetomidine also has a short half-life, the combination of this wears out of your system pretty quickly. And they do this actually quite often for cases that you want to extubate in the OR. Remember I said this patient was an ASD and was extubated in the operating room. So they're looking to offset analgesia without sedating them to the point where they can't breathe on their own. And so they pick agents like these that are short acting that would wear out of their system pretty quickly so they could extubate them. If you pay attention when they hand over, they always tell you that they've given a few doses of morphine here and there before coming, and that's because morphine is much more longer lasting than sufentanil. But depending on when that dose of morphine was given in the OR and when they actually arrive to you, and by the time you do the x-ray, you can very much be in a state where your analgesia has worn off, which is why in this case, and cases similar to this, thinking about pain is always a good safe start. And also knowing your medications is also a good sort of way to tell you, or it's a good trigger to know where to start when you're trying to figure out what's going on. For sure, when you want to consider how children react to certain anesthetics, knowing which ones that have been given is also very helpful. Some actually have a paradoxic response to others, and well, most of our anesthetists are pretty good at telling you if they have observed things like that as well. So another really key point that I want to make is always when you want to try to manage patients who are like this, have a plan moving forward, because a strategy that you apply for a certain point in time may hold for that point, but it's always good to have an ongoing strategy. And so in this case, what we do here is we oftentimes give them a Tylenol load that is given rectal, and now actually we're giving it IV for a certain subgroup of patients. And more they're giving it in the OR than we are in the unit, but the idea is to build on the synergy between Tylenol and morphine. And oftentimes our kids actually are put on routine Tylenol that they sort of have standing every 4 hours for the first 3 days post-op. And again, that's just to offset the effect of pain and build on the synergy between the two. More often than not, we tend to start a background infusion of morphine at 10. And that's only because it tends to keep them more regulated and controlled and calm in the first few hours post-op. But you can actually get away with giving intermittent morphine boluses as long as you're on top of and mindful of where your patient's pain is at, and that you're squaring it off in and actually, intervening as needed. So you can go either way. We strongly also try to start them on routine ketorolac, which is IV ibuprofen. This also works really well in conjunction with your Tylenol and intermittent morphine. With this combination, you're sort of tackling the pain receptors from multiple different angles to get good control of analgesia. Okay, and I always add parents as sort of a measure of comfort for these patients, because it does actually make a big deal of difference. So our second case. This is a 3-year-old boy with cardiomyopathy. Your ejection fraction on last echo is 30%. And the patient is in your care in the ICU for management of shock and heart failure. He is sitting on your unit with some BiPAP and has a CVL and art line that we put in on admission. And we're managing his heart failure with milrinone, epinephrine, and a Lasix infusion. And of course, he is made NPO. Same old story. You come to his care and you find him, at the beginning of your shift, crying, tachycardic with heart rate into the 190s. He is hypertensive, and he's, pretty steady with those physiological parameters. He has an increased degree of, an increased work of breathing, and is clinically very cool and clammy. Your monitors are ringing off, everybody's crying. What do you do? So again, I'm going to ask you the same questions. What do you think is going on? So starting off with, is it pain? Why or why not?
He's agitated.
Sorry?
He's agitated.
Yes, so why do you think it's agitation? Why or why not?
Because of the BiPAP.
True, BiPAP can definitely contribute to agitation. If you ever have a chance to try one of these on, I highly recommend it, but maybe do it with a friend nearby, because it's not pleasant. So I agree, there is a degree of agitation, and I completely agree with that assessment. Do you think it could be pain?
It could be from hunger, but he didn't have a surgery.
True, so it's not surgical pain. He could be hungry and also, probably a little bit ticked off because of that. But you're right, it's unlikely for it to be pain as a result of anything that we are doing to him. Having said that, given his background, it's always important to assess for pain really diligently, because he's a perfect setup for someone who would develop neck and therefore have pain as a result of ischemia to his bowel, given that he has a low ejection fraction and he is on inotropic support, he's being managed for shock. So he's definitely set up for, end organ injury in the setting of low output state. And so he should definitely be very closely monitored and assessed for pain. But in the absence of an organic cause, I agree that it's unlikely for him to be in pain. Agitation, aside from the BiPAP mask, can also be caused by, again, being in a low output state, and that actually does cause a degree of agitation on its own in the absence of an organic source of pain. And again, that would fit in the setting of the story. Can it be delirium?
Unlikely, but he's not on any sedations or dexmedetomidine.
I agree. So he's been just admitted to the ICU. He's acutely ill, so he's a little bit young. I'm trying to just get to, he's a little bit young to develop agitation, to develop delirium as a result of acute illness. And he hasn't been exposed to any drugs sort of prior to this event. And so in that setting, it's unlikely for him to be in pain, in delirium, and therefore the most important thing and probably the first thing to try and tease out is agitation. So given that, let's try and see how we're going to manage this. So again, like I said before, we should break the cycle. And in his case, he's already exhibiting symptoms of not being able to physiologically tolerate what's going on. With his work of breathing, he's cool and mottled and pallor. So given all of the above, it's really important to minimize his metabolic consumption and to try and settle him. And so one of the best drugs probably for this is the use of dexmedetomidine. For the most part, it has very little, it has not literature doesn't show that it causes or contributes to a big degree of delirium. And so it's presumed to be fairly protective against that. And it also doesn't quite have as much of a hemodynamic profile as some of the other sedatives do, like the benzos. So it tends to be pretty safe for this group, with the only major side effect being bradycardia. And you usually see that in the setting of giving big boluses. If you generally just start with an infusion, it tends to be pretty safe. So for this reason, you want to avoid bolusing dexmedetomidine. I guess just food for thought, if you are in heart failure and you're tachycardic, that's how your heart is trying to make up your cardiac output and to try and sort of meet your demand. So if you very abruptly drop it, you could actually end up in an arrest state because the heart that isn't already coping all that great given its own mechanics. When you take away the ability to regulate the heart rate, you can basically collapse the whole cardiovascular system. So for two reasons, you really want to be careful, but as an infusion, it's actually a good drug for this case. The other thing to consider is you can actually give small doses of fentanyl, again, because it doesn't have much of a cardiac effect. It tends to be pretty safe with respect to blood pressure and other things. So you can consider, in addition to your dexmedetomidine, given small boluses of fentanyl. And if you are in a state where you have to do procedural sedation, ketamine is also a good drug, again, given its hemodynamic profile. You can have mom and dad come by and try and offset the agitation, but sometimes parental presence can also exacerbate the agitation. So just sort of judge that based on each individual case. Your focus here, in addition to managing agitation and anxiety, is also to try and decrease metabolic demand to try and preserve cardiac function as much as you can while your heart failure therapy is catching up with him. And so your longer term plan actually in the first place is heart failure management. That is the cause to your agitation, and it's actually not going to, your agitation isn't going to improve all that much until you manage the heart failure to some degree. Dexmedetomidine infusion, like I said, is very helpful, and you can start with some PRN fentanyl, and oftentimes if they end up intubated or you hit like a max dose of dexmedetomidine, you can consider a low dose fentanyl, again, from its hemodynamic profile. Minimal handling is also key here. So case 3. I have 2 more cases, this one and one more. So this is a 6-month-old girl with AVSD post-op day 1 from AVSD repair. She does not have Down syndrome. She has a long history of feeding intolerance. And she was admitted to your care from the OR, extubated only on Marinone at 0.5. She is, so this is the next morning, and you find her on a dexmedetomidine infusion at 1. She's on a morphine infusion of 10. She's getting PRN ketorolac and is getting her routine Tylenol, like most of our post-op kids do. She's had, however, during the course of the night, as you hear the story, PRN boluses of Benadryl, lorazepam, and morphine, all of them to offset agitation, but they each have had very short-lived effects. And she's now on high flow and not looking great. So same deal, you are trying to figure out what is going on. And I'm gonna ask you again, do you think it's pain? Why or why not?
No, it's not pain. Probably not.
Yeah, I agree. It's probably not pain. She's on good medications. She's on a morphine infusion in the background, and she's received PRN boluses with minimal effect. And I've described a patient who is at baseline sort of not settled and not happy. So there's nothing that's triggering the pain. So while it's possible, it's not likely. Is it agitation? Pure agitation. Yes. There is a degree of agitation, I agree. And that's in the setting of being post-op, being a little baby, and probably not tolerating your feeds. Yeah. But can it be delirium?
Yes, 100%.
I agree. So this patient, actually, when we scored her, I think she had a score of 19 or somewhere around there. And one of the clues actually to look for is this last piece here. So I've said she's had boluses of Benadryl, lorazepam, and morphine in the past few hours, each of them lasting a very short time. So from a pain perspective, she's pretty well captured. She's on morphine infusion, ketorolac, and Tylenol, and the combination thereof should cover her pain. She's on a dexmedetomidine infusion at 1, which you would think should offset your agitation. And in the setting of the fact that you've had to give so many different boluses with minimal effect, this speaks to it being delirium. So what do? For her, remember how I said she has a history of feed intolerance? We switched actually her oral Tylenol to IV so that we can take away this question around whether she's absorbing her Tylenol or not. And in so doing, if there was also an element of her being upset because of her tummy being upset, we sort of took that off the picture. We converted the PRN ketorolac to routine, again, to target her pain receptors from a multimodal approach and to really try and to cover for pain, and to again have like a clearer picture and a clearer sense of what's going on. And we were left with now trying to manage delirium. Given that the only drug she was on from a sedation perspective was dexmedetomidine, we decided to come off of it because that was the only thing that could potentially be, in addition to the environment, that could potentially be exacerbating her presentation and contributing to her delirium. So we dropped it off to half and then eventually to off completely. We rotated her morphine to hydromorphone, again in the setting of the fact that morphine, the studies show that can cause or contribute to delirium more than hydromorphone. So by rotating it out, we tried to minimize the pharmacological effect to exacerbating that presentation. And And again, we still wanted to make sure that we were managing her pain because she was only 1 day post-op. She was very tachycardic and hypertensive, which in the setting of kids that have AVSD repair and oftentimes have an AV valve repair, you really don't want them to be very hypertensive. So instead of piling on various sedatives, we decided to control it with nipride for the most part, and just a little bit of clonidine as we were coming off of dexmedetomidine fairly abruptly. And we really modified her environment. So we put in place lots of comfort measures, regulated her day and night cycles, controlled the noise, and allowed for her parents to be there. And we were able to get on top of her delirium pretty effectively. But if you were to be unable to achieve control, then there would be a need to then move towards a medical management of delirium, which for the most part for our patients, the drug that is most favorable is probably quetiapine. So a psych assessment and then starting quetiapine with close consideration for QTc changes. Our last case. So this is a 14-month-old girl with dilated cardiomyopathy, now post-Berlin LVAD implantation. She initially came to us to the hospital 12 days ago, let's say, in the setting of cardiogenic shock, was intubated on day 2, and then had her LVAD implanted on day 5. She was otherwise well at home and didn't have any developmental delays or genetic abnormalities. And now that you see her, she's been 7 days since her LVAD implantation. She is on a dexmedetomidine infusion at 1, a fentanyl infusion at 2, that was at 6 yesterday, and we decreased it for extubation. She's getting routine diazepam that was dropped to PRN yesterday, and she's on routine Tylenol. She is extubated, of course. We made all these changes to be able to do that, and she's on high flow. And other than her LVAD and her PICC line that she had before and an NG, she really doesn't have anything else going for her. So you come to find her as before, agitated, crying. She has a heart rate into the 180s. She's very restless. She's pale. She's constantly moving about and crying. And she has a work of breathing that we're trying to offset by high flow, but it's really not catching up. And you've been told that the night before it was more or less the same. It actually started the night before, but that the story you knew from previous to her extubation was that she was actually a pretty nice, calm, and interactive girl. So what's going on? Is this pain?
Less likely, maybe.
Yeah, so she's 7 days out. It's less likely for her to be in pain, and she's on a considerable amount of drug to actually offset pain on its own. She's on a fentanyl infusion, which should be more than enough to cover for Berlin cannulas. So I agree that it's unlikely for it to be pain on its own, but there could be a tiny element of it. Is it agitation on its own?
Probably not.
Yeah, probably not agitation on its own. She doesn't have a whole bunch of stuff going on, and she has her parents and everything else around her. There could be a degree of agitation associated to having these, Berlin cannulas on her that she didn't have before, and she's only a few months old, so it'll take her some time to get used to that extra hardware. But it's unlikely for agitation on its own to be able to explain the degree of distress that you're seeing. Can it be delirium?
Yes, definitely.
Absolutely. This is a kid who's been sick for a very long time, is on loads of drugs, and it could definitely be delirium. Yes. So we should for sure score her and then see what we can rotate and change to try and minimize the contribution from delirium. But I'm also going to ask you if it's withdrawal.
It could be. She was 12 days intubated.
Yeah, so we dropped from a fentanyl infusion of 6 to 2 in a heartbeat, which is a huge drop. And keep in mind that fentanyl is actually lipophilic, so it dissolves in your fatty tissues and it leaches into circulation for a long period of time. But when you cut the infusion really, really abruptly from a big dose to a small dose, you tend to really offset that ability to sort of auto dose yourself from your fatty deposits, and you can go into withdrawal very quickly. So in her case, the biggest bulk of her agitation actually came from being in withdrawal. The other thing that they had done was that they had dropped her routine diazepam to PRN. And so in that setting, she also hadn't received any benzos, and from both agents, she was in major withdrawal. So you want to break the cycle. Like I said, she's not, she's already starting to be compromised, and you want to try and break the cycle. So you want to potentially give a new agent to make it effective. You can potentially consider a small dose of ketamine or maybe a bolus of fentanyl and see where you're at. Ketamine will take care of the agitation, and if you're convinced it's fentanyl, which was the case here, a bolus of fentanyl can give you a sense of whether it'll settle on its own, and it'll be almost like a definitive diagnosis for withdrawal. You want to increase your fentanyl infusion to 4 or 5 and just see where you settle out, keeping in mind that she is extubated and you don't want to suppress her drive to breathe. And you may end up having to do some more creative things to try and offset some of these withdrawal symptoms. And you can sometimes see like a Narcan infusion even at times. You want to return her diazepam to schedule as it was before and try and limit her PRNs to 1 agent only so that you can really streamline and figure out what's going on and be able to treat effectively. For her case in particular, we actually consulted psychiatry right away because we knew that we needed additional agents to try and manage this delirium effectively. And she was on she had been on medication for some time that we were sure that delirium was also a contributing factor to this agitation. We implemented a lot of environmental controls, and we put in place a very gradual wean of sedatives for her over a period of time. So with that said, do you have any questions for me? Was that helpful?
I'm sure it was.
Okay.
I do have one comment that says Azzy's presentation is really great too. I like the format of case scenarios.
Oh, thank you.
People are responding now. Very helpful. Thank you.
Thank you, Azzy. You're amazing. Thank you, Azzy.
Thanks, Irina. I appreciate it. So if you have any questions or anything, I'm happy to answer. You can email them my way. I'm actually pretty quick on email. And if not, you can just catch me in person if you happen to be here. But otherwise, that is it for my slides.
So Azzy, I posted the one without the answers in the thing. Now I can post the one with.
Please. And if you'd like it in PDF, I can convert it.
No, it's okay. I can convert it. That's fine.
Okay.
Yeah. Thank you so much.
Perfect.
Okay.
Thank you.
Bye.
Bye.